Welcome, fellow learners, to another deep dive. Today, we're plunging into something really vital in veterinary medicine, especially for our equine friends, the enzyme aspartate aminotransferase. You probably know it as AST. Maybe you've seen it on a lab report if you've had a horse that wasn't quite right, or maybe you're just, super curious about how their amazing bodies work. So, our mission today, we've got a stack of expert sources on equine AST. We're going to break down what it is, where you find it in the horse, what makes its levels change, and critically, how understanding AST helps us figure out what's going on with a horse's health. Think of it as your shortcut to getting really well informed on this key diagnostic tool. Okay, let's get started. At the most basic level, what exactly is aspartate aminotransferase?
Right, so at its core, AST is an enzyme. It's a protein that um, basically speeds up a specific chemical reaction inside cells. It's all about moving amino groups around, part of normal cell metabolism.
Mm.
Now, when cells get damaged or leaky, this enzyme, this AST, escapes into the bloodstream, and that's what we pick up on a blood test. It's also interesting, there are actually two forms. There's a cytoplasmic one, COST, released with milder damage, maybe reversible damage. And then there's a mitochondrial form, MAST. That one comes out when the damage is more severe, affecting the cell's powerhouses. Routine labs don't usually split them out, but knowing they exist helps understand the potential severity.
Got it. So it's like a worker inside the cell, and if the factory wall breaks, the worker gets out. A leaky worker signaling trouble.
Exactly. That's a good way to think about it.
So if it's leaking out, where are these workers normally found? Because knowing that seems absolutely crucial for interpreting an elevated level on a report you might get.
Absolutely. AST is found in high concentrations in several different tissues, most notably skeletal muscle, the big muscles for movement, also cardiac muscle cells, the heart, and hepatocytes, which are the main liver cells. Oh, and also erythrocytes, red blood cells. They have quite a bit too. It's found in the kidney and intestine as well, but usually they don't contribute as much to the really high levels we see in common diseases. And the normal range, well, it varies a lot between labs, from maybe 48 up to over 450 IUL. So you always have to check the lab's specific reference range.
Okay, so it's not pinpointing one specific spot, then. It sounds more like a general building alarm rather than a smoke detector in one room. It tells us something's happening, but not exactly where, right?
Precisely. That general alarm idea is perfect. And understanding its kinetics, how it behaves over time in the bloodstream, that's really key for interpretation. And here's where it gets, well, quite interesting. AST has a much longer half-life in horses compared to other common enzymes we measure, like creatine kinase, CK, which is very muscle-specific, or the liver-specific enzyme SDH, sorbitol dehydrogenase. The AST half-life reports vary a bit. Some say 3-4 days, but it's generally considered around 7 to 8 days.
7 to 8 days, that's quite a while compared to CK, which is just hours, right?
Exactly. And that extended half-life is a critical piece of the puzzle. It means AST levels peak later after an injury, usually 24 to 48 hours after the insult, compared to CK, which peaks much faster. But here's the real takeaway. Because it sticks around so long, AST stays elevated for days, maybe even weeks, even after the initial problem is resolved, and other enzymes like CK have already gone back to normal.
Ah, I see.
So this makes AST really useful as an indicator of, say, ongoing or resolving chronic injury. If you see high AST, but the CK is normal, it's like an echo. It tells you something was happening, or it might still be smoldering.
That's fascinating. So it's not just a snapshot. It gives you a bit of a timeline, a progress report almost. But hang on, it's not just disease or injury that can bump up AST levels, is it? What else can mess with these readings? Things that might mislead you if you're not careful.
You're absolutely right. There are several things besides clear pathology. Even just normal strenuous exercise can cause mild, maybe moderate increases. That's just physiological muscle turnover, tiny microtraumas. In fact, performance horses in heavy training, they might naturally have baseline AST levels 50% or even 100% higher than a horse that's hanging out in a field.
Okay, so exercise is a big one.
Yeah. And another huge one is hemolysis. That's the breakdown of red blood cells. It can happen inside the horse, in vivo, or just during sample collection and handling in vitro. Remember, red blood cells have lots of AST. So even a little bit of hemolysis can falsely increase the AST number on the report.
Ah.
So if you get a report back and the sample is noted as hemolyzed, you have to take the AST value with a grain of salt. Also, severe lipemia, that's fat in the blood, or icterus, jaundice, can sometimes interfere with the lab assays themselves. And this all points to why sample handling is just so crucial. Leaving a sample sitting out too long at room temp or repeatedly freezing and thawing it, that can cause red cells to break open, falsely raising AST. Or the enzyme itself could degrade, lowering the value. So best practice is prompt separation of the serum. And if you can't analyze it within a day or two, freeze the serum. Refrigeration is generally okay for up to 24 hours.
Wow. Okay. That really highlights the complexity. You got exercise, sample handling. So if AST is in so many tissues and influenced by all these other factors, how do vets actually use it? How do they figure out what's triggering that general alarm and diagnose the real problem? That seems like the million-dollar question.
It absolutely is. And this is where the deep dive really helps, pulling together what the sources say. Since AST is high in both muscle and liver, figuring out the primary source is job number one. And the key, as you might guess, is to look at AST together with other more organ-specific enzymes. AST alone, it just lacks that specificity.
Right. You need backup singers.
Exactly. So for muscle injury, the absolute gold standard in horses is creatine kinase, CK. It's super sensitive and very specific to muscle. CK shoots up really fast, peaks maybe 6 to 12 hours after an injury, and its half-life is super short, just a few hours. So it usually drops back to normal within 3 or 4 days after the acute injury stops.
Okay, so CK is the quick-reacting, specific muscle alarm, and AST is the slower, longer-lasting echo we talked about. How do they work together then?
That's a perfect way to think about it.
Mm-hmm.
If you see both CK and AST elevated, that strongly points to acute active muscle damage. Think exertional rhabdomyolysis tying up or maybe significant trauma. And in those acute cases, the CK jump is usually way bigger than the AST jump. But if you see elevated AST and the CK is normal or back to normal, that suggests the muscle damage is resolving, or maybe it's a chronic lower level issue because the fast-acting CK has already cleared out, but the long-lasting AST is still hanging around.
Right, the echo is still there.
Exactly. You see this pattern sometimes in horses with subclinical myopathies, these underlying muscle issues that aren't always obvious. We might also look at lactate dehydrogenase, LDH. It's less specific than CK, but if it's up along with AST and CK, it adds supporting evidence for muscle involvement.
It's really neat how the timing and the combination paints that picture. So what are some common muscle conditions where you'd expect to see these patterns play out?
Well, the classic one is exertional rhabdomyolysis, or tying up. You get really marked elevations in both CK and AST. And as the horse recovers, you watch both. But the AST will stay high longer. Tracking them both is key for guiding when it's safe to go back to exercise.
Makes sense.
Then you have conditions like polysaccharides, Dorje myopathy, PSSM, or myofibrillar myopathy, MFM. These can cause chronic or kind of sporadic increases in CK and AST, even if the horse isn't showing obvious signs of tying up. Severe muscle trauma, or even just a horse being down and unable to get up for a long time, prolonged recumbency that causes massive enzyme release too. And even infectious myositis, muscle inflammation from an infection, can push those enzymes up. Okay, that covers the muscle side pretty well. Now, what about the liver? If we suspect liver issues, what are the key players alongside AST? Right, shifting to the liver. Here, sorbitol dehydrogenase, SDH, is really considered the most liver-specific enzyme in horses. Very little activity elsewhere. But it has a short half-life, only about 12 hours, and it's quite labile. That means it breaks down easily in the sample tube.
So that sample handling issue is even more critical for SDH.
Extremely critical. You need to analyze it super fast, within hours ideally, or keep it properly chilled right away. But if handled right, SDH is an excellent indicator of acute liver cell injury and how it's resolving.
So how does SDH work with AST to tell the liver story?
Well, if you see both elevated SDH and AST, that's a strong sign of active liver cell injury happening right now. And the size of the SDH increase, assuming good handling, can be a more sensitive marker of that acute damage than AST. Now, conversely, if AST is high but SDH is normal or only a little bit up, that might point towards more chronic liver disease or maybe an acute liver issue that's already resolving. Or it could mean the high AST is actually coming from muscle, not the liver.
Okay, so the pattern between AST and SDH gives clues about timing acute versus chronic.
Precisely. Another liver-specific one is glutamate dehydrogenase, GLDH. Like SDH, it indicates liver cell injury. But the good thing about GLDH is it's more stable than SDH, half-life around 14 hours. So it's a really valuable alternative, especially if getting that SDH analyzed super quickly isn't possible.
Good to have options. What about GGT and ALP? I hear those mentioned with liver too.
Right, gamma-glutamyl-transferase, GGT. This one is linked more to cholestasis problems with bile flow or injury to the bile duct lining. GGT has a long half-life, weeks sometimes, so it can stay elevated for a long time. High GGT along with high AST, maybe SDH or GLDH2, points towards significant hepatobiliary disease. Really high GGT, say over 400 IOL, often suggests a poor prognosis. But little caution here. You can see mild GGT elevations in perfectly healthy racehorses in training, or foals, donkeys, mules, sometimes even with gut issues. So a mild GGT bump alone doesn't automatically mean liver disease, especially if other tests are normal.
Context is everything.
Again, always.
Yeah.
And then alkaline phosphatase, ALP. It's found in the liver, related to cholestasis again, but also in bone, intestine, placenta. So it's less liver-specific than GGT. It can be up in chronic liver disease, but it's not as helpful on its own compared to GGT, SDH, or GLDH for pinpointing liver injury.
Wow, okay, that's quite the toolkit of enzymes. So thinking about actual conditions, where would these patterns be crucial for diagnosis and liver problems?
Okay, so for acute hepatocellular injury, think things like Thieler's disease, certain toxicities, maybe acute cholangiohepatitis, you'd expect to see big jumps in the liver-specific enzymes like SDH and GLDH along with AST, and you'd likely see clinical signs too, jaundice, lethargy, poor appetite. For chronic liver disease like chronic active hepatitis or maybe pyrrolizidine alkalotoxicity from certain plants, AST might be persistently elevated, often with GGT. But SDH and GLDH might be normal or only slightly up because the damage is ongoing but less intensely active. Yeah. Clinical signs in chronic cases can be subtle at first and progress to bigger issues like photosensitization or even hepatic encephalopathy. If the main issue is biliary obstruction, a blockage in bile flow, you'd primarily see really high GGT and ALP. AST might be elevated too, kind of as secondary damage. And just a note, simple anorexia, a horse not eating, can cause a rise in unconjugated bilirubin, making them look a bit yellow, but it doesn't usually cause big AST spikes unless there's underlying liver disease. Even some gut diseases can sometimes cause mild liver enzyme bumps, including AST, maybe from endotoxins or bacteria moving up from the gut.
That's a really important point you brought up earlier. These enzymes like AST, SDH, GLBH, they tell us about cell damage or leakage, right? But do they actually tell us how well the liver is doing its job, how well it's functioning? That feels like a critical difference.
You've absolutely nailed it. That's a crucial distinction. These leakage enzymes indicate hepatocellular damage or injury. They tell us cells are unhappy or breaking. They do not directly assess liver function. How well is the liver actually performing its vital tasks? For that, especially when we suspect liver disease, we need additional liver function tests. These are indispensable.
Okay, so what are these key function tests we need to look at?
Right. Top of the list is usually bile acids. These are a primary indicator of hepatic function. The liver is supposed to clear bile acids from the blood. If they're elevated, it suggests the liver isn't doing that job properly, either due to liver cell dysfunction or a blockage in bile flow. A neat thing in horses is because they don't have a gallbladder, their bile acid levels aren't really affected by whether they've just eaten or been fasting. Makes them quite reliable. Markedly high bile acids, say above 20 up bile L, and especially if they get really high, like over 100 in chronic cases, that's generally linked to a poorer prognosis.
Okay, bile acids are number one. What else?
We also look at bilirubin, total, but also the split between conjugated and unconjugated. High total bilirubin, especially if the conjugated fraction is high, more than about 25% of the total, suggests cholestasis, that impaired bile flow again. High unconjugated bilirubin can happen just with anorexia, like we mentioned, or with hemolysis. Then there's albumin. This is a major protein made by the liver, so if albumin levels are low, hypoalbuminemia, it can indicate chronic liver failure because the liver isn't making enough. Though other things can lower albumin too, like inflammation or losing protein through the kidneys or gut. So again, context.
Right.
Next, blood urea nitrogen, BUN. The liver converts toxic ammonia into urea. So if BUN is low, especially if ammonia levels are high, it suggests the liver's failing at that conversion job. Serious dysfunction.
And that leads to ammonia itself.
Yeah, exactly. Ammonia. High blood ammonia is a hallmark of hepatic encephalopathy, the neurological signs you see with severe liver failure. It means the liver just can't detoxify it anymore. Measuring ammonia needs special sample handling. It's quite volatile. Glucose is another one. The liver is key for blood sugar control. So in severe acute liver failure, you might see hypoglycemia, low blood sugar because the liver can't make glucose properly, and finally, coagulation factors. We measure these with tests like prothrombin time, PT, and activated partial thromboplastin time, APTT. The liver makes most of the proteins needed for blood clotting. So if these clotting times are prolonged, it suggests the liver isn't making enough clotting factors. That points to significantly impaired function and a risk of bleeding, often seen in severe liver disease.
Wow. It really shows how the liver is involved in so many things. So putting it all together, We have AST showing us potential damage, and then this whole panel of function tests telling us how well the liver is coping. How do we combine all that information to actually understand a horse's likely prognosis? What's the outlook? That's what everyone wants to know, right?
Absolutely. And the prognostic value of AST, well, it's complex. It absolutely has to be interpreted within the full context, the suspected disease, how high the AST is, how it's changing over time, the trend, and critically, alongside all those other markers we've discussed. While we look at the number, the absolute value of AST is often less predictive than the trend we see in repeated measurements over days or weeks.
So watching if it's going up or down is more important than the number itself sometimes.
Often, yes. Is the damage ongoing, getting worse, or starting to resolve? That trend tells a story. For instance, a mild AST elevation, maybe 2 or 3 times the upper limit of normal. That's pretty nonspecific. Could just be exercise, mild soreness. Prognosis is likely good if it's self-limiting. A moderate elevation, say 4 to 5 times normal, suggests more significant injury. But marked elevations, especially if you're talking more than 10 times the upper limit, that usually signals severe active muscle or liver injury. And that warrants a more guarded, maybe even poor prognosis, especially if other signs of organ failure are popping up. And like I said, a declining AST trend is generally a positive sign, suggesting the injury is resolving. Stable or increasing AST. That suggests ongoing or worsening damage.
Right. So focusing on muscle disease for a second. How does AST help with prognosis there, given its long half-life?
Yeah, for muscle disease, that long half-life makes AST really useful for monitoring recovery. In a case of acute tying up, the initial CK level tells you how severe the acute hit was. But then watching the AST gradually decline over the following days and weeks, along with a horse looking better clinically, that's a really good sign. It indicates a favorable response to treatment. If that AST stays high or starts climbing again, that's worrying. It suggests ongoing muscle damage, or maybe points towards an underlying chronic myopathy that needs addressing. In those chronic myopathies, persistently elevated AST, even if only mild or moderate, tells you there's ongoing muscle compromise. The prognosis then really depends on whether you can manage that specific underlying condition.
Okay, that makes sense for muscle. Now, what about liver disease prognosis? How does AST fit in there, especially with all those function tests?
For liver disease, AST's prognostic value is absolutely tied to those other liver enzymes and, crucially, the function tests. High AST alongside high SDH or GLDH suggests active liver cell death, which naturally makes the prognosis more guarded. If you have high AST and really high GGT, remember the bile flow enzyme, say 400 IUL, that often points to severe hepatobiliary disease, maybe significant cholestasis or bile duct changes. That usually indicates more chronic, severe damage and a poorer outlook.
So the combination is key again.
Absolutely. But critically, for liver disease prognosis, the most powerful indicators are off of those liver function tests. Really high bile acids, especially persistently over 101 Potter-Galeals in chronic cases, combined with high AST. That indicates significant loss of function and carries a guarded to poor prognosis. Interestingly, if a horse has high AST but normal bile acids, the problem might actually be muscle damage or maybe just mild liver damage that isn't affecting overall function significantly.
Ah, that's a really useful distinction.
Yeah. And if you see elevated ammonia or clinical signs of hepatic encephalopathy, that's very serious, regardless of the exact AST level. It signals severe liver failure and a grave prognosis. Similarly, low albumin or prolonged clotting times, PTA, PTT, along with high AST. That points to the liver failing in its manufacturing duties, impaired synthetic function, and suggests a poor prognosis for recovery. Jaundice is common. But if you have persistent severe conjugated hyperbilirubinemia with high AST, that suggests significant cholestasis and a more severe form of liver disease. And ultimately, for the most accurate liver prognosis, a liver biopsy is still the gold standard. Looking at the tissue under the microscope, seeing the amount of cell death, inflammation, scarring, fibrosis gives invaluable information, often using specific scoring systems. Okay, so bringing it back, if you, the listener, are just looking at one number, the AST value on a lab report, what's the big caution? What's the main limitation to keep in mind? The critical takeaway is recognizing AST's limitations when viewed in isolation. Its non-specificity is the biggest hurdle. Without looking at it alongside CK for muscle or SDH, GLDH, GGT, and those crucial liver function tests, its prognostic value is severely limited. You just don't know the source or the functional impact. And because of that long half-life, the trend over time is often much more revealing than any single snapshot number. Plus, always remember, AST reflects cell leakage or damage, not necessarily how badly the organ's function is impaired.
Right, that damage versus function point is huge.
Exactly. You could have a horse with sky-high AST from muscle damage, but feel perfectly fine otherwise systemically. Compare that to a horse with only moderately high AST but showing signs of hepatic encephalopathy. That second horse has a much, much worse prognosis, even though the AST number itself isn't as dramatically high. And of course, you always have to mentally filter out those non-disease factors like recent heart exercise or potential sample handling issues. Context, context, context.
That's a powerful reminder. Never look at one number in a vacuum. Okay, looking towards the future. What's developing? Are there new tools or approaches on the horizon that might help us get even better at interpreting AST or diagnosing these conditions?
Yeah, that's a great question. There are definitely things being explored. One area, though not routinely available yet, is the potential to differentiate between those two forms we mentioned earlier, cytoplasmic AST, TRACS, and mitochondrial AST, MAHEST. Being able to measure them separately could theoretically give much more refined information. Remember, CST suggests milder, maybe reversible damage, while MAHEST points to more severe, possibly irreversible cell injury. Knowing which one is predominantly elevated could offer immediate clues about severity.
That would be really informative. What else?
Research is always ongoing into novel biomarkers, things like specific microRNAs or miRNAs, tiny molecules that can be very specific signals for different diseases. There's also work on developing even more sensitive advanced liver function tests and exploring acute phase proteins more, like serum amyloid A, SAA. SAA is a very sensitive and rapid indicator of inflammation, which often accompanies significant tissue injury, whether it's muscle or liver.
So getting more specific signals, maybe even faster signals of trouble, how do the existing advanced tools fit in when you have a complex case with high AST?
Right, for optimal diagnosis and prognosis, especially in tricky cases, you really need to integrate everything. That includes diagnostic imaging using ultrasound, for example, to look directly at the liver's size and texture, or to scan muscles for lesions. And as we touched on, biopsy, getting actual tissue samples from the liver or muscle, remains the definitive way to diagnose certain specific conditions, like PSSM type 2 in muscle, or to get that crucial histological detail and prognosis score for liver disease. Genetic testing is also becoming increasingly important for identifying specific inherited muscle disorders.
So it's really about layering all these different types of information.
Exactly. And finally, never underestimate the power of serial measurements. Repeating those AST tests, along with the other relevant markers, over time, it's invaluable for tracking the response to treatment and reevaluating the prognosis as you go. Seeing those AST levels trend downwards is a great sign that your management plan is working. If they stay high or keep climbing despite treatment, well, that suggests the plan isn't working. Maybe the diagnosis needs revisiting, or the disease is unfortunately progressing. And remember, while getting back to the normal range is the goal, complete normalization of AST can take weeks, especially after severe or chronic injury, simply because of that long half-life. Patience is needed.
So let's wrap this up. What have we really learned from this deep dive into equine AST? I think the big nugget of knowledge here is that while aspartate aminotransferase, AST, is absolutely fundamental in assessing a horse's health, its presence in so many different tissues means you can't just look at the number alone. Its true diagnostic power emerges when you interpret it systematically, integrating it with those other more specific enzymes like CK, SDH, GLDH, GGT, and especially with those crucial liver function tests, plus maybe imaging or even biopsy findings.
Well,
It's about building the whole story, right? Not just reading one word.
precisely. It's detective work using multiple clues.
So for you, our curious listener, the takeaway is that understanding a single lab value like AST is really just the first step. The real insights, those aha moments, they come when you connect the dots, when you consider the entire clinical picture, the trends over time, and piece together the full puzzle. Now, here's something to think about. If we can gain such a detailed, nuanced understanding by looking at just one enzyme in a horse this way, by integrating multiple pieces of information, imagine how applying that same deep dive, multifaceted approach to other complex information in your life could transform your understanding and maybe even your decisions. What other areas, what other puzzles might benefit from looking beyond the surface value and exploring all the connections? Keep that curiosity alive.